All right, Salim Rezai here, and we're going to talk about the treatment of hyperkalemia. So there's really four categories you need to know: membrane stabilization, shifters, excretors, and then definitive care. So let's go through each of these one at a time. So when we talk about membrane stabilization, we're talking about calcium gluconate or calcium chloride or hypertonic 3% saline. So how do you dose these medications? Well, typically for calcium, it's 1 amp given as an IV push. For hypertonic saline, it's going to be 50 mLs given as an IV push. The next thing we need to know is what's the onset time? And for both these medications, it is immediate. As soon as you push it, you should have immediate effect. And then the last thing you need to know is how long, once you give that medication, does it last? And for calcium gluconate and chloride, it's anywhere from 30 to 60 minutes, so about half an hour to an hour. And for the hypertonic saline, it's not really crystal clear. Let's move on to shifters. So this is going to be our short-acting insulin or albuterol nebulization. The dosing for these is going to be for insulin, 10 units IV push plus 1 amp of D50 because we don't want to make our patient hypoglycemic. Now, there is some evidence that maybe in patients that are dialysis patients, maybe 5 units of IV push insulin is all that's needed. I'll let you make that decision based on an individual basis. For albuterol, we're talking big dose, 10 to 20 milligrams given as a neb over 10 minutes. So again, what's the onset of action? So for insulin, it's going to be about 20 minutes, and for albuterol, it's going to be about 30 minutes. How long does the effect last? 4 to 6 hours for your insulin D50, about 2 hours for your albuterol. The third category is your excretors, and there are really 3 that fall into this. There's furosemide, bicarbonate, and then sodium polystyrene sulfate, also known as K-exolate. So the dosing for each of these. For furosemide, 40 to 80 milligrams IV, I will tell you that I typically go with 80 milligrams. If I'm giving it, I might as well give it. For bicarbonate, I'm not talking about amps of bicarb. I'm talking about 3 amps of bicarb mixed in a liter of saline, run as an IV drip. So I'm doing this to buy me time till I can get to definitive care. And for the K-exolate, I almost never use this. There are case reports of colon necrosis, and the effect, as you'll see in a minute, is so slow that I don't find it very helpful in the acute setting. But it's 15 to 30 milligrams PO in patients that can tolerate PO. The onset time for each of these is going to be 15 minutes for your furosemide. For bicarbonate, it's going to take hours for you to really see the effect. And then for the K-exolate, the onset time is greater than 2 hours, which is why I don't really like using this medication in the acute setting. How long do each of these last? For your furosemide, you'll get 2 to 3 hours. For your bicarbonate drip, it's as long as you have the drip going. And then for your K-exolate, it's going to be 4 to 6 hours. And then finally, you have definitive care, which is what we're trying to get our patients to, which is going to be hemodialysis. Now, the onset is immediate. Once you start dialysis, it works pretty quickly. The problem is getting all the pieces there, so you have to buy time with all those other medications that we've already discussed. And then how long does it last? It lasts anywhere from 3 to 4 hours. So this is a table I created with each of those 4 categories: your membrane stabilizers, your shifters, your excretors, and then your definitive care. You can see that I have the name of the agent for each of those categories, the dose, the onset time, and the duration time. We probably need to know all of these things so that we know that if it's taking time to get definitive care, we may need to redose our patients. So there you have it, treatment of hyperkalemia. Let me know your thoughts and comments and questions. Thanks for tuning in, and until next time.